The following program is a Town of Colony television production of the William K. Sanford Town Library.
I'm the director of Dignity-Albany. Just as a general review, I thought I would say a couple of words about the legislation that we're advocating for. You know, Dignity-Albany does two things. We put on programs like this that deal with a wide variety of end-of-life issues, and we also advocate for the passage of medical aid in dying in New York. So let me just tell you a little bit about what the law is, and then we're going to hear about where we stand in terms of getting it passed. Medical aid in dying would allow a mentally competent adult who has a diagnosis, a terminal diagnosis with 6 months or less to live, the ability to ask their doctor for a prescription for medicine that they would take on their own. They call it self-ingest, if and when their suffering becomes too great. This is not suicide. It's not a physician-assisted suicide. These are people who want to live, but really don't have that option. They are dying, they are terminally ill. So it's really important to understand the distinction. If you hear somebody calling it assisted suicide, you can jump right in and explain why it's not suicide. And that's an important distinction because but for better or worse, there's a kind of a stigma about suicide. So these are people who want to live, who have gone through treatment, tried every treatment that's available to them, and they are out of further options for treatment. So that's the distinction. They simply want to die peacefully and on their own terms. And the law that we have before the legislature is based on the law that has existed for 22 years now in Oregon. And it's now also the law in 7 additional states besides Oregon, plus Washington, D.C. The law has been passed in Vermont for several years now. It's based on the Oregon model because it's worked so well. It's worked exactly as intended without any reports of abuse of the law. And that's how we know that it works. So the law has been passed in Vermont. The law has recently been passed in New Jersey, and it's time for it to be passed in New York State. So that's what we're working for, and we had a very successful lobby day last week, and quite a number of Dignity-Albany members were there, and I was very proud of our representation. And I'm going to call on Nancy Willie Schiff now to give you a little more detail about where we stand in the law and what can be done, what you can do in terms of taking action.
Hi, thanks Bonnie for some time. I'm bringing you a message from Corinne Carey, who is the director of the Compassionate Choices campaign in New York to pass medical aid in dying. She tells us that the campaign is in full swing and there are 15 days left in the legislative session, and that the vast majority of bills pass during this period. The Medical Aid in Dying Act still has to pass the Senate Health Committee and the Codes Committee in the Senate and the Assembly Health Committee and the Codes Committee in the Assembly. And then it can be brought to a vote on the floor of both houses. During the last few months, our campaign has focused on building support among new members of the legislature, because there are many new members, and also on focusing on the members of the relevant committees. So far, we have 49 co-sponsors, which is amazing. And in addition, the really good news is we have the votes to pass the bill in the Senate Health Committee. Now, the slightly bad news is the opposition is heating up, and they are driving hundreds of phone calls to the members of the Senate Health Committee and handing out glossy flyers in the Capitol, many of which misrepresent the bill. So Compassionate Choices doesn't take this sitting down. They've organized a phone banking campaign asking people to make 25 calls to supporters who either signed petitions or made donations or did something and gave their name and phone number to Compassionate Choices. And we're asking people to make one phone call to their senator or assembly member to either shore up their vote or, in the case of the assembly, ask for their vote. And we need your help in this effort. And if you really care about this legislation, this is the time to come forward and help. We've never been closer. So we're looking for volunteers to make phone calls, and Jeff will be passing out sign-up sheets. We need your name, phone number, and email address. The only reason I need your phone number is in case I can't read your email address. And we're also asking you if you'd be willing, when there's a vote in one of the committees, the health or the health committee and the senators or assembly, if you would come. That is also really helpful, so you can volunteer to do that. And since we live in the capital region, it's easy for us. And also, there is a new member of the Assembly Health Committee named Jake Ashby. Do any of you live in his district? He's in Rensselaer County, and all the way from Greenwich in the north down to near Catskill, Hudson in the south. And he said before the election that he supported this. And he's now in the Health Committee, and his is a key vote there. So if you can join us for a district meeting, you can sign up to do that. Or if you're in his district and you just want to make a phone call, I made little strips of paper with the information you would need to make a phone call to him. Anything you can do, this is the time to do it. Thank you.
To our program for today, we're pleased to have Jennifer Hoit with us today. Jennifer is a registered nurse with 10 years experience in home care nursing. She's worked extensively with patients from hospitalization and or diagnosis of an illness through admission to hospice, and ultimately to the end of life. Oftentimes, her patients and their families avoided talking about death until a crisis situation arose, and they often did not go into hospice care until they were actively dying. Jennifer felt that there had to be a better way to facilitate peace and acceptance for her patient and for their families at the end of life. She found her answer through completing end-of-life doula training. Jennifer believes that there is no less beauty at the end of life than at the beginning, and her passion is fueled by her intention to bring the community together to support and care for the dying and their families. She is a doula's caregivers consultant. Care consultant, let me do that again. She's a doula giver's care consultant and is also trained to discuss advanced directives as well as end-of-life wishes. Jennifer?
Hello, thank you everybody for coming. If you can't hear me, let me know, because I am a little vertically challenged with the microphone. So I have been doing, actually now it's been 11 years in home care nursing, and I've never been a part of hospice, but I worked for a home care agency called a CHA. So a CHA is for acute cases. So a CHA home care nursing agency would care for a patient out of the hospital, and we'd follow them for a number of weeks, and then once they got stable, we would discharge them. So being that a home care nurse case manager is in the same geographic areas, I would have a patient get out of the hospital, the patient would get better, would become stable, I would discharge them. A few months later, they would come back. So I had the pleasure and the privilege to develop a rapport and relationship with these patients and their families. And I was noticing more and more that, number one, patients were going to hospice too late. A lot of times they would be actively dying and maybe get 2 or 3 days on hospice services, which it's really a shame because hospice has so many wonderful services to support families at end of life. And if the patient was only on hospice for 3 days, it would really be a shame, and there was a lot that the family had missed out on. So I'll tell a story about one of my most special deaths that I was a part of. I had a client who was in his 50s, young man, healthy man, worked full-time, would come home every day, grab his dog, and take a 5-mile hike. So he was living with a significant other. They had mortgages and car payments like all of us. And he noticed he was tripping as he was walking up the stairs one day and went to his doctor. Ultimately, he was diagnosed with a form of ALS. The only difference between this neurological disease and ALS was that his diaphragm was never paralyzed. So he could not move from the neck down. He could feel sensation, but he couldn't move. So he had to be fed. He was full care. His wife was feeding him breakfast one morning, and his coffee went into his lungs. He aspirated. So his wife called 911. The ambulance came. They never took the mulched form off the refrigerator. The mulched form is that bright pink form that has what your wishes are. He was a do not resuscitate. They never took it. They lost him in the ambulance. They brought him back, and he woke up in ICU on a ventilator. So being that he was paralyzed, he had 2 joys left in his life, and that was to talk and to eat, and he no longer could do those things. So because his family didn't want to lose him, he decided he would go into a facility that manages ventilators. When someone's on a ventilator, they can't go home unless they have 24-hour care. And his wife, being that there's car payments and mortgages, still had to continue working and didn't have access to 24-hour care. While he was in the nursing home, which lasted maybe about a month, he decided he had had enough. And he was going to write his own story about his death. So the nursing home transferred him to Ellis Hospital because you cannot be weaned off a vent in a facility. You have to be at a hospital where they can give medications. And he was empowered enough at that point that he gave direction on exactly how he wanted his end of life to be. He didn't want to suffer. He told the doctors and nurses, I do not want to suffer. Medicate me with whatever you need to so I don't struggle and I don't suffer. I want a shot of Jack Daniels before you turn the ventilator off, and I want my best friend to come with his dog. And the hospital agreed upon all of those, and they gave us a private room in the corner, and we were there for the day. We played his favorite heavy metal music after they turned the ventilator off. And he was a healthy man. His heart was healthy, so he was actually able to stay awake, communicate, say I love you, say goodbyes for many, many hours, even after they turned the ventilator off. And it was such a beautiful experience because here was a man, a young man, and it was a tragedy, but he wasn't suffering. He took his power back and decided how he wanted to die. And he did die very, very peacefully with his friends and family all by his side. His friends had an opportunity to come and kiss him goodbye, and we all told stories, and we laughed, and we cried, and it was just a beautiful experience. I have found in my work that the most beautiful deaths happen when the family is in acceptance, the patient's in acceptance, and you have support of neighbors, church members, family, doulas, hospice nurses. the medical professionals, it just goes much better than a family who is not accepting, doesn't want to talk about it. So part of my aim is to just get people to talk about death. You know, we plan for vacation, we plan for Christmas, we plan for retirement, we never plan for death. And sometimes it takes a crisis situation to get that conversation going. But I feel that the conversation would be more beneficial if it happened before that crisis situation. So I am an end-of-life doula. Years ago, I knew I always wanted to work with the dying. I thought I had to become an RN to be able to work with the dying. But the definition of doula is actually a non-medical person that is trained to care for somebody at end of life. So as a doula, we give people physical, emotional, and spiritual support to someone else as they're preparing to leave this life. An end-of-life doula is a non-medical professional that provides a holistic support for the dying and their loved ones before, during, and after death. Trained in the various end-of-life stages, a doula is able to assist the family with understanding the natural processes while providing comfort and support. So, in a perfect world, a doula would be involved with the family and the patient giving at-home care before that health crisis, so that there would be a rapport and a relationship built between the family and the patient. And when the patient dies, a doula's job isn't over, because that's when the grieving starts, and there's no time limit on grief. And hospice is wonderful for what they do, but a lot of times when a patient dies, that family loses that hospice nurse that they've developed such a relationship with. So the family almost goes through a second loss because they've lost that relationship. An end-of-life doula can also be called a death doula, a death midwife, and an end-of-life guide. So we provide support and care for those in the last phases of life-limiting illness. And doulas don't just come in when a patient has a month left to live. There's a lot of chronic illnesses, congestive heart failure where the body fills up with fluid, or chronic obstructive pulmonary disease where breathing gets very difficult. A doula can be there in support for those chronic illnesses before it's at that stage where it's terminal. Part of what we do is we recognize dying as part of the normal process of living. So we want to talk about it. We want to hear, can you hear better? Oh, I walked away from the microphone. So because we know it's normal and we're all going to die, we can help that family process their feelings and their fears. And we focus on quality of life for individuals and their family caregivers. The whole part of being a doula is empowering that patient and their family at end of life. A lot of times, if someone has gone through treatment for cancer or any other chronic illness, you become part of the medical system. Your life is consumed with tests and doctor's appointments and blood work. And we have such a conversation, such a wording around fighting an illness. If you read an obituary, it'll say they fought valiantly till the end and they lost their battle with cancer. So you have a patient that's fighting, and then all of a sudden they get that news from the doctor that there's nothing else that they can do. And that crumbles their world. And I've seen it a lot of times, and it can happen so quickly. The doctor says, I'm sorry, there's nothing more I can do. We're going to put hospice in. Hospice comes and does their evaluation, and I've had the privilege of actually being present for a lot of them because my patients didn't want to lose me. They wanted me to be a part of their decision, so they would ask me to be in on the hospice evaluation. And hospice is wonderful. They come in and they do a comprehensive evaluation. They're talking to the family, but there's just so much information all at one time. I could see my patients and their family just after about 10 minutes, they can't absorb any more information. So the doula is there to carry on that teaching when hospice leaves and for those hours in between those nurse visits. The doula is there to say, hey, remember when the hospice nurse said that we can give your dad a little bit of this medicine to help him sleep a little better or help him to relax? That is the main part of what a doula does. So why do we need end-of-life doulas if we have hospice, which is a very common question. Due to Medicare reimbursement guidelines, the hospice team has a very limited time that they are able to be with the actual patients. And I've seen this as a home care nurse. There's a productivity that every home care nurse has to uphold. And it doesn't matter if you have a family in crisis, you still have 6 other patients to see that day. So there are very tangible time constraints on a hospice nurse visit. And I have known a lot of hospice nurses. I'm friends with several hospice nurses. And they will work 12, 16-hour days to make sure that their patients are taken care of. The hospice team manages the care of the terminal patient. And they hold the cornerstone for end-of-life care. They order supplies. They order medications. There's a doctor always there if they need an order for something else. We can't have a good death without hospice. They're ordering the hospital bed. They're on call 24/7 if needed. They've got social work. They've got chaplains. They have a plethora of resources. They have volunteers. A lot of volunteers do therapeutic touch. They do Reiki. It's something that we definitely need. And I find in my work, I continue to be a nurse case manager for Landmark. I find that when I bring up the conversation of hospice, families think that hospice is going to provide 24-hour care. And hospice really is there to teach the family how to care for the patient. So it's a huge letdown when the family thinks, oh good, hospice is going to come in, I'm going to be able to sleep. The hospice nurse or the aide will be here all night long. Hospice is there to teach the family how to take care of the dying. And a lot of the problems with home care nursing and hospice are the insurance constraints because they're so strict. And a lot of times, and because I was a home care nurse, I know this from experience, you can spend an hour with a patient, but you've got 45 minutes of documentation. So a lot of times the nurses in the home, they're trying their best to complete this documentation that has to be very particular for the insurance companies, and they're trying to give the family support. So as doulas, we work in conjunction with hospice to carry on that teaching for when the hospice nurses aren't there. So we are attending to the emotional, psychosocial, and spiritual aspects of dying and caregiving. And we're also advocating for the patient and family. And we are the additional support systems to patients and family with no time limitations. End-of-life doulas, we are not under an insurance. We're not covered by insurance because if we were, it would mean we would be under the same time constraints. So unfortunately at this time, it's a private pay service. I am hoping, and that's why I do these talks, is to get as many people trained so that these services can be available to anybody in need, regardless of what their financial situation is. And we serve as the eyes and ears of the hospice program. Doulas have a relationship with a patient that they can tell the least little nuance that is off. They can sense almost a new symptom that's arising. When I did home care nursing, if I had someone in the home, a caregiver, that was really in tune to a patient, I would give them my cell phone number. Because if they can call me up and let me know this is going on, and I can take care of that symptom before it blossoms into a crisis situation, it's better for the patient, it's better for the family, it's better for me. So these are some sobering statistics. 78 million people over the age of 65 in the United States. Our baby boomers are all aging. 9 out of 10 people say they wanted to be cared for at home at end of life. And what happens a lot of times, if a patient and their family don't have the support of a doula or hospice, a symptom is going to arise, and even though that person wants to stay at home and be at home when they die, the family gets nervous and anxious, ends up bringing that patient to the hospital. And anybody at end of life, if they go to the emergency room, they will be admitted because they definitely have a medical issue. And sadly, they don't return home to die. They end up dying in ICU or on a hospital floor. And to me, that's very sad. And 20% of the 78 million elders do not have any children. And I'm seeing it more and more in the home, these people who have no one. They might have an elderly sister who lives in Florida, but they have no children, they have no spouse. It's just them. So there definitely has to be a change as far as end-of-life care is concerned. So end-of-life doulas are filling that gap. We are developing a relationship with the patient, with the family, with the hospice nurses. And we are the go-between. So the benefits of the end-of-life doula is we provide companionship and presence, emotional support, and interaction. A lot of times, families they're in such distress because they're losing a loved one. They're afraid of death, that they don't know how to interact with that person anymore. So the doula sometimes, and I've seen it in my own work, we become kind of like a model. We have somebody who's dying and the family's afraid to touch them. It's a doula that says, it's okay to touch them. It's okay to talk to them. They hear you. Even though their eyes are closed and they look like they're sleeping, they still hear you. Earlier intervention, as they serve as the eyes and ears of hospice. And that's going back to if a symptom arises and a patient's having a hard time breathing. That doula can call the hospice nurse, report those symptoms. A medication or an intervention can be ordered before it gets to the crisis situation. And it serves for an increased sense of autonomy. It gives the person who is at end of life their power back. They're no longer just a product of the medical system, the number that's going for CAT scans and PET scans and getting blood tests. That doula is letting them write what they want their story of end of life to be. We provide better coping skills and helping families make peace. And there can be large families or small families, very interesting dynamics. But because that doula comes in and that doula is non-judgmental and a neutral party, sometimes you'll see the energy shift with the family and conversations are had that need to be had that might not have happened if you didn't have that neutral party there. Longer and more frequent visits as needed. And that's also going back to the autonomy of the patient and family. The patient and the family say how often they want the doula to come, how many hours on what days. All the decisions are coming from the person who's dying and their families. We also assist with making memories, funeral arrangements, obituaries, and memorials. And doulas are trained to be up on the latest funeral processes. A lot of times when someone passes away, hospice would come, they would clean up the body, and the body would go. Actually, there's a little bit of a change with that because in New York State, a body can actually stay in the home for 24 hours. So people are actually going back to a little bit of a home funeral where it helps with the grieving process. It helps with saying goodbye. I know that when my mother died, I was a nurse, and I didn't know how to do my mother dying, but I knew how to be a nurse. So it was a great privilege for me to be able to bathe her, to be able to take care of her, even after death. We hold space and help family members cope. As doulas, we go in with a very non-judgmental presence. And we're a little bit of a quiet energy in the home. And of course, if there was a situation that needed intervention, hospice has wonderful social workers that are trained to deal with any sort of family situation. But we encourage the conversations, and we notice a little nuance if there's a family member that's having a very difficult time. The doula would take that person aside and talk to them one-on-one and go over what their feelings are. We've all been affected by someone who has passed away, and there's a plethora of emotions: sadness, anger, and then there's guilt for feeling anger, and it's just such a multitude of different feelings that to have a neutral party to be able to talk out those feelings really helps. And we set the sacred space. And again, that is up to the person who is at end of life. They say exactly what they want to see, what they want to be surrounded with, whether it be beautiful pictures, whether they want their bed facing the window so they can see the birds and they can see the flowers, what family members they want to visit. It's all giving that person their power back. The benefits to the family is continuous guidance and support with no time restrictions, education on the natural end-of-life processes. We can explain the stages that a person's body goes through as it's breaking down. So instead of it becoming a crisis situation where the family wants to call 911 and have that person brought to the hospital, the doula can say, this is very normal. This is what's going to happen. We can turn her over and make her more comfortable, but this is how a body dies. We can also provide respite care, allowing and encouraging needed rest of caregivers and family. Once a rapport and a trust is built with the family member and the doula, it's so important to let that family rest or even go out for an hour to go shopping, something to get out and just have that family member participate in their own self-care. Almost like the birth of a baby. We want the dad to rest before that baby comes. It's the same thing with end of life. The family wants to be present at those last few moments. Let them rest before that happens. And we can also assist with locating bereavement resources, and a lot of doulas actually stay with the family after the death because that doula was such an integral part of that death that the stories and the processing has that doula there. And so that doula will facilitate that healing by helping to process the whole experience because he or she was there. So the end-of-life doula benefits to the hospice is increased length of stay. It has been proven that if someone's pain has been managed, if they are supported emotionally and spiritually, they will actually live longer than what the doctors had projected. So what happens is a patient will go under hospice. They've got the doula taking care of them and allowing them to go over life review, make their end-of-life choices with them. You've got hospice that's managing the pain level, ordering supplies for them to make their quality of life better in the home, and they will end up living longer. And increased satisfaction. The families are very happy to have that extra person in the home that's there, that doesn't have a time constraint, that can be called and said, hey, can you come over for a couple of hours, just for that added support. And when you have families that are satisfied, families will make referrals. A lot of it is just word of mouth. As far as volunteers go, volunteers that are end-of-life doulas, and there are several that are, it increases their satisfaction in their work and what they're doing. And it also increases employee morale. And it's a benefit to the hospice because it's expanding their services. So what's the difference between a hospice nurse and an end-of-life doula? Time and roles. The hospice nurse is a medical manager of the terminal patient with limited time at the bedside due to insurances. So the medical piece of it is managed by the nurse. Need for medication, need for pain control, supplies, things like that. The doula is overseeing the emotional, the physical, and the spiritual aspect of the dying process. And again, the doula giver is the one that is the go-between between the hospice nurse and the patient. So what is the difference between a hospice volunteer and an end-of-life doula? The end-of-life doula can do everything except give medication. That is not our scope of practice, is to give medication. And end-of-life doulas don't do any sort of nursing care as far as wound care or anything like that. If there is a doula that is comfortable and trained, they can provide personal care. But that is usually up to the doula's discretion. And also safety has to be considered. You know, I'm a little girl. If I have a patient who's 6'4", I'm not going to attempt to walk that patient at end of life to the bathroom. So the hospice volunteer still follows Medicare regulations. And for some reason, and it has to do, I believe it has to do with insurance regulations, a hospice volunteer is only allowed 4 hours with a particular patient a week. And I'm thinking it must have something to do with insurance reimbursement, but I have some doulas that are volunteers that will actually go back to a patient's house and say, just don't tell them I'm here, but I know you need extra support, I'm going to come back. So insurance does not cover it, and that's basically because we don't want to be under the same time constraint as the hospice nurses, the home care nurses. We want to be available and there at any time when the patient or family needs us. And during transition, hospice nurses are available by phone, but they're not always available to come over. That end-of-life doula is there from the beginning of transitioning until that patient passes and after. So the end-of-life doula can help with the funeral arrangements. Sometimes with a lot of families, that's also a process that's left to the very end. And sometimes it's a matter of the funeral arrangements. I had a patient at one point that the patient was actually transitioning, and I sat with the family and had to call a couple of different funeral homes because she had Medicaid, and Medicaid will only be accepted at certain funeral homes. So it was a little bit of a process. What services and support will hospice provide for me after my loved one has died? And what does the doula giver provide for grief support? Hospice does have bereavement, and they will reach out to the family and be of service to them. But again, a doula has unlimited time to spend with the family as far as bereavement. What can a doula giver, end-of-life doula do that a hospice home health aide can't do? And again, everything is time. Most hospices provide home health aide services up to a maximum of 2 hours a day, 5 days a week. And that is the very maximum. And what I've seen in my work is you have someone who's at end of life and their 87-year-old wife is taking care of them, and their children are working full-time and have children of their own. So you've got this little frail elderly woman taking care of her husband. So she's thinking that hospice is going to come and be there for hours and hours, and it's a very limited time frame. And also its availability of home health aides. We're at a crisis level with home health aides. There's not a lot that are available. Is there a government licensure for end-of-life doulas? There's not a government licensure, but there is a certification and there is a training, just because there has to be some sort of checks and balances with people who are going out into the home and doing this kind of care. So there is NEDA, which is the National End-of-Life Doula Alliance, and they oversee the doulas with core competencies. A doula would have a background check. That would be part of the process to become a doula. And an end-of-life doula can also be involved in the home during the palliative care phase. There's palliative care, which is for patients that have that chronic illness. It's not necessarily at a point where it's terminal at this point, but palliative, the premise of palliative care is symptom management, managing those symptoms so that that patient stays out of the hospital. We only have one chance to have an end-of-life experience go well. Together, we are putting progressive, holistic initiatives in place to make that happen. And this is from Suzanne O'Brien, who was actually a hospice nurse downstate. She is the woman that I work with. And she was finding more and more these huge gaps of lack of support that the family had. So she actually started this movement. And she started the Doula Givers organization in which I work with, just to get that information out about end of life. So does anybody have any questions?
Yeah. A bit more just because we are specifically trained. But again, it's up to the doula and it's up to financial need too. It would probably be around 20 to 25 an hour, yes. And some doulas do
Like a package, there's a one sum for all of the services. Others do an hour by hour situation. But my feeling is if we get more people trained to do this work, and actually it's a work that someone in every family should be trained, because we're all going to be taking care of elders in our family. We're going to be taking care of neighbors. If we had one person in every family trained to be able to take care of that person that was dying, people would have a much more positive experience at end of life. Yes?
Could you tell me a little bit more about what the training entails?
The training entails, it takes about 9 months, and you can either take it self-paced or you can do webinars. Suzanne actually teaches the certification classes. So basically you go through the stages of end of life, and a person going through the training would be taught modalities to support the patient and the family at these different stages. She also teaches the diseases that are the top fatal diseases where a person would pass away from, symptom management, things like that. Yes?
Where are they given? In Albany?
She's actually in downstate in New York City, but the webinars are all online.
Are most doulas female?
There's actually some males that are becoming doulas. It's like nursing. Nursing used to be such a female-dominated profession. Now there's a lot of men that are going in.
Do families ever express a preference?
Yes. Yes. They do. But on the other side of the coin, if you have somebody at end of life who's 6'4", and a male would be more appropriate to be able to give that help with the personal care or turning the patient, things like that. 100 years ago, actually the women in several cultures and tribes would be the person that would birth the babies, would take care of the sick, and would help the people at the end of life. So that initially is where the term doula came from and this kind of work. So we're going back to community-based assistance at end of life. We're bringing the community in, making it less of a medical situation and having it more a personal, a more human experience. And that's why the emphasis is on non-medical people.
Is it a worldwide organization?
It is a worldwide. Actually, Suzanne O'Brien has worked a lot in Africa where there is a lot of HIV. She goes there at least once or twice a year to help get people trained and to do this work. So it is becoming worldwide. And you can look up the National End-of-Life Doula Alliance, and they explain where we are nationwide. She's asking where we are in numbers of doulas in this area. So you're meaning upstate New York. New York City, it's taken off. There are a lot of end-of-life doulas out there working with hospice, doing the work. Upstate New York is just a little bit slower. And that's why I go out and do these talks to get the word out and explain what an end-of-life doula is and how we can benefit end of life.
So how many are there like in this capital district?
In the Capital District, certified, there are almost four of us. 3 have graduated, 1's on the way. So it's getting there, just a little bit slower. And a lot of it is getting doctors on board. Doctors are so focused on curative, and they feel it's a failure to refer hospice or have a patient go to hospice. When I was seeing patients in the home, I would call the doctor because you can't go under hospice services unless you have an order from the physician. Because I was seeing this person 3 times in the home a week, I could tell that they were at end of life, and I would call a doctor and say, do you think Mrs. Smith is appropriate for hospice? You never tell a doctor, you ask a doctor. Yeah. And they would say, oh, no. They're going to continue with treatment, and a lot of times the patient would die the next week, the next 2 weeks, within a month, and it's a tragedy. So a lot of it is changing the doctor's perspective on dying and having it not be such a failure, but actually by giving that person, that patient who's at end of life, their power back, it's a victory. Sometimes letting go is the victory.
Yeah, that's exactly.
Right, and usually,
A person will stop eating at end of life. It's just a part of their body shutting down. It's a very normal part of it. So it's not even to say that you would have to tell your mother, well, you're just not going to eat, and that's going to help things along.
No.
It's just part of the dying process. And the story that I had told in the beginning, they heavily medicated him, so there would be no struggle, because that would be horrifying for the family and for him to have seen him struggle to breathe. So they made sure there were a lot of medications on board, and they were giving it towards the end about every 8 minutes.
Well, that's, and that's
Yeah.
the optimal way. And also, I couldn't be there when my mother passed because I didn't know when she
Right.
was in this slow.
I'm so
and-
sorry.
Yeah, that's one of the reasons I support this bill.
Right.
Because people shouldn't have to go through
Right.
that. And hospice is not always the be-all and end-all, as
Right.
good as they are.
Right. And even though a doula
Can't give medications, the doula would suggest it.
Yeah.
Like, Dad is getting a little agitated. Remember, the nurse said that we can give this. Why don't you give him a dose, and we'll see how he does. So the doula is there kind of monitoring when he's given medications, but we just can't actually physically draw it up and give the medication. A doula stands alone. Yes. Yep. We're not hired by hospice. We work in conjunction with them, but we're not affiliated with them. Online. Doula Givers has a national list of all doulas listed in an area, and we also have communication between us all. If there's a doula needed in Lake George, New York, a message will go out, hey, is anybody close to Lake George? There's a doula needed. So we're growing by leaps and bounds.
What's the website?
Doula Givers. Yes.
So
We're talking about how hospice holds that cornerstone of symptom control. Pain is a big one, but also someone who's having difficulty breathing, someone who is getting the increase of secretions at the end of life. Hospice has access and the knowledge to be able to order and administer and teach on these medications that are going to help with these symptoms. You know, the worst thing in the world is to have your family member at end of life and they're struggling to breathe. There are a lot of medications that can calm everything down. Or at the end of life, having the noise of those secretions. There are medications that help with that because there's nothing more distressing than families trying to say goodbye and there's these scary noises and it seems almost like the person is drowning. There are medications that the hospice nurse brings in, teaches the family how to give it, the dosage to give, and when to give it. And that's why we can never have a good end of life without hospice. As much as the insurance has limited the time that hospice nurses can spend, we can't do it without hospice. Yes. Others are also interested in doula givers because we can go over the advanced directives. A family will go to a lawyer to have their will written out, and they'll ask questions about the medical aspect of it, of feeding tube and versus not having a feeding tube and dialysis. So lawyers are seeking us out to be able to sit with the patient and their family to explain what these different modalities are and talk it over. Is that something you really want? I know a lot of times when you go to a doctor, a patient doesn't think they have a choice. I've seen people that are end-stage kidney failure, and the doctor will say, well, that's all right, we're just going to start dialysis, we're going to put the fistula in next week, and we'll start it. And these people don't have any idea what dialysis entails. They don't have any idea that it entails being in a dialysis center for 3 hours, 3 days a week, and you're going to be exhausted the next day and not be able to do anything, and by the time you feel a little bit better, it's going to be time to go back to dialysis. Yes. MOL stands for Medical Orders for Life-Sustaining Treatment. But if you have a healthcare proxy and a living will, those would be sufficient. And it's also a good idea to have more than one healthcare proxy in case one is not available. And another little tidbit is if you are your spouse's healthcare proxy and you get divorced, that healthcare proxy is null and void. Unless you do another one, if you want the ex-spouse to be your healthcare proxy.
They might not want to keep you alive.
Exactly. I think that's why they made the law where it would be null and void in the event of a divorce. Yes. Not to have a co-healthcare proxy, like if he had 2 children, a son and a daughter, having the son being one and having the daughter being one, because they might not agree. Now, a lot of fallacy is, too, people will name somebody a healthcare proxy and say, oh, my daughter knows what to do. A healthcare proxy, the point of it is you tell that person that you are entrusting with your wishes exactly what you want done and what you don't want done, and that person carries it out. It's not like they're deciding for you. Everybody should have a healthcare proxy, no matter how old or what kind of health they're in. If you designate somebody, you tell them exactly what you want done or what you don't want done, and that person carries it out. I had an elderly neighbor who was estranged from her family, very nice lady, she's outside shoveling during a snowstorm. A month later, she ends up in the hospital, and she's in renal failure, and she's dying. She named one of my neighbors a healthcare proxy and never told her. And never said what she wanted at end of life either. So here was this woman completely stuck between a rock and a hard place because now she's this woman's medical advocate and has no idea what she wants and didn't even want that responsibility. So it's a good idea to really talk about that healthcare proxy. Has anybody gone onto the website, The 5 Wishes? Yeah. Oh, the 5 Wishes is this, this beautiful form that I don't know who created, but it's free online. Oh, he's got one. Can you pass it around so people can see it? And actually, at Landmark, we give all of our patients the 5 Wishes, and it's just a very nice, nice, easy to understand form that you can fill out that puts down what you would want done at end of life.
She's asking about community hospice homes, like
There's the Joan Prince home in Schenectady, I think it's in Rotterdam. Gateway of Peace, I believe it's in Saratoga. Actually, the 2 end-of-life doulas that were certified in this area very recently, they work at the hospice home that's in Saratoga. So yes, we are in the hospice homes.
You've got a job, you've got a client that is actively dying. How do you manage that
It's
person?
not
Do you have a team that you
it
work
has to
with?
be a team effort. And it has to
Do you
be,
work with other doulas
Yes.
to provide for this
Yes.
individual? It's not like you yourself or
Right, because
a
they're-
single practitioner.
no, and there's no way you could ever do it as a single.
Single practitioner, because as a caregiver, we are at risk of burning out ourselves. So it's always a team effort. So it would always be where a family and a patient has a rapport with 2 or 3 other doulas, because transition can last 24 hours, it can last longer, no one knows, and that doula is not going to leave. But if there, you know, it comes to a point, or you have an appointment, you have a life, you have children, you can say, I really need to go, but you know Mary, and she's going to come and take care of you. They just want to know that somebody's going to be there and somebody that they know and have that relationship with. But it's definitely a group effort. It's all about community and getting people trained in the community. So as a community, we can help support people who are dying. Very welcome. This was a pleasure. Thank you, everybody.